we'll go over the appropriate procedure. I had some videos, but the internet is not working right now. So that's fine, you don't need one. We're gonna walk you through the procedure as we do it on it. But they're in the notes section, the videos, so I mean, if you wanna watch them after, I would recommend doing that, because we'll go over the technique today and why. So here's our objectives, our indications, contraindications. Complications are important to pay attention to, and then we'll talk about insertion, maintenance, and removal. All right, so what are our indications? And we kind of talked about it throughout the last, 4 lectures, because most of them did involve some form of chest trauma or another, or our primary and secondary survey. So anybody with a pneumothorax, any hemothorax, pleural effusion. I mean, the overall goal is to either remove air or fluid from that pleural space. It is probably the most frequent procedure that we use in the management of blunt penetrating trauma in the trauma room. And then we can also use it for chronic conditions as well, like we talked about on our last block for those, the different types of like pleural effusions that may not be trauma related. All right, so what are our contraindications? Yeah, there aren't any. And even our indications is, like an experienced clinician, it's actually pretty broad indications for a chest tube. So if you have any of those signs like we were talking about before, any like unilateral chest rise, diminished breath sounds, respiratory distress, they have any sort of penetrating injury anywhere in the thorax, they're typically going to get a chest tube. And like I said before, it is a clinical diagnosis. It doesn't require any sort of imaging, and there aren't really any absolute contraindications. So things we need to consider, like relative contraindications, are any of those patients, like those COPD patients, they might have some emphysematous blebs. We need to think about scarring as well in the lungs. And then anybody with like multiple pleural adhesions, and then obviously our coagulopathic patients are other considerations that we should think about prior to placing any chest tube. However, if the patient is an extremis and they're unstable, they're still likely going to get a chest tube, and we may not know any of this information beforehand, but if we have the time, we should consider these things prior to any sort of tube thoracostomy. All right, so what kind of complications do we have? So bleeding is probably one of the most common, and then injury to surrounding structures, which is why we're going to teach you a specific technique that you're using so we can avoid these complications. And for bleeding, we tend to use 3 maneuvers to avoid the bleeding. That's why we recommend going above the rib versus below the rib, because when you go below, you have your neurovascular bundle under there, and so you can get quite a significant amount of bleeding if you improperly place this tube. We also do a 360 finger sweep after we've entered the thoracic cavity, the pleural cavity, with our finger, so we can verify that we're in the right location. And then we use a controlled pleural entry for these. And we'll show you how we do that with our Kelly forceps and the proper technique. But we can certainly injure a significant amount of structures in that area. I mean, we have our vital vasculature, we have the heart, the aorta. If we use a safe, appropriate technique, we can avoid the diaphragm, the liver, and the stomach, but it does happen. Everybody is anatomically different, but we tend to use a standard guideline, and it may not work for everybody, or you may have messed the procedure up. Typically, when we're doing these, and we'll talk about the next slides, we like to go a little bit higher in the thoracic cavity versus lower if there's any concern. And then we also have to think about infection, and then any sort of whether they have any allergy or anesthetic reactions, and then porocosmesis. I mean, that's the patient's problem, right? Yeah, they're likely going to have, possibly some porocosmesis, but luckily in the area that it's at, it's usually covered by most of the clothing that people wear. But most of the complications are caused by us. All right, so here's our overview and where we're going. So obviously we recommend between the 4th and 5th rib or 5th intercostal space, at the mid-axillary line, and we want to make sure we're well above the diaphragm. In men, we typically say the nipple line. A good rule of thumb, I was trained one up from the nipple line, but the nipple line is the appropriate or the textbook location that we place these. In females, we use the inframammary fold as the location. And then we have what we call our triangle of safety, which we'll go over in some of the next slides. And we tend to stick to that area when we're placing the chest tube. And it may deviate a little bit with the location because they could have some sort of injury in that area. And then there's obviously, depending on the size of the patient or how fluffy they are, that you may have to adjust the location you're going to insert that tube. But typically we do that 4th and 5th intercostal space, or the 4th and 5th rib and that intercostal space in between it. And then what we like to do is make an incision on top of that rib. So we use that rib like a cutting board, the lower rib, and then we like to bluntly dissect with our Kelly forceps above that rib and into the pleural cavity. So as you can see, that's picture B there on the upper right, and that's our controlled pleural entry we like to use. And then once we bluntly dissect down there, we like to open up our forceps and enlarge that area so we can get a finger and a tube in there. All right, so what do we do before the procedure? If the situation permits and they're stable, it's nice to have a pre-procedure chest x-ray, especially when we're looking at the less acute procedures, like whether they have some sort of large effusion that we're looking for. So location does help if we get a pre-procedure chest x-ray in those patients. And then obviously we want to position our patient appropriately, and we'll look at the next slide, but obviously, it's best to have their upper extremity over their head when we're doing this procedure. And then we got to think about what chest tube size we're using. Typically in a trauma patient, we're using a 36 French, and that's what comes in your guys' medical equipment sets in the Army. I can't speak for the other services, but I'm sure it's similar. But there are smaller ones if we're looking at spontaneous pneumothoraxes that we can use, whether it's an 18 or 20 French chart. Our other considerations, or what we call a pigtail catheter, can suffice. But what we need is typically a chest tube kit. So in the hospital, we sterilize the entire kit that's listed here together. Unfortunately, in your guys' roll ones and your medical equipment sets, they have pre-made chest tube kits. They're really expensive, so sometimes you may or may not have those and everything is packaged together. However, they do issue the units a bunch of unsterilized equipment so you can make your own kits. So you do have to think about where can we get this autoclaved and sterilized if we're concerned about doing chest tubes. Hopefully you guys can get chest tube kits, but if not, you need to think about all these considerations of what goes into that kit, and you may have to make it yourself, unfortunately. We list the equipment there, but obviously you need your hemostats, which is typically your 2 Kelly forceps. You need a scalpel blade, preferably a number 10, scissors, some sort of anesthetic. Skin marker helps. Syringes with needles so you can anesthetize the area. And then drapes, and then typically Zero Silk is what comes in most kits for suturing that chest tube in place. And then we have our skin prep solutions in there, whether that's betadine or hexadine or whatever the other ones are that they have. And then we need to get a post-procedure x-ray as well. So here's our proper positioning. I like how they have that strap there. I've never had a strap that we actually could use, but typically we just move the patient's arm over their head. If they're conscious, great, you can have them place their hand behind their head for this procedure, or you may have to have somebody else holding their arm up if you're not able to do that. They also, certain places may have arm attachments that can go to the beds. That's common in the OR, not really anywhere else, but they typically, you want to have them supine or reclined, either is fine. And then you want to make sure you're comfortable when you're doing this procedure. So you want to raise the bed up if you're taller, you want to lower the bed if you're shorter, so that you can comfortably perform this procedure. And then you want to identify your triangle of safety. So that's going to be your pectoralis muscle on the medial border, your latissimus on the lateral, and then inferior is your 4th and 5th intercostal space. And then it's helpful if you can mark the incision site over top of that 5th rib at the mid-axillary line. And then you want to prep and drape them. So typically we want to clean up with some sort of sterilizing solution in circular motions. And a lot of times we use betadine for this. And then if you have some, like, the kits usually come with fenestrated drapes or 3 to 4 towels or both in some of the kits. And then you want to ensure that it is an aseptic technique. So it is a sterile technique. You are going to be wearing your sterile gloves for this, not your exam gloves. So typically, like when we run the trauma room, I typically have a scalpel in my pocket. I have my sterile gloves, like still packaged in my pocket. And then just so we know this is going to be an emergent procedure typically, so we're prepared for this prior to any sort of patient presenting to the trauma room. And then obviously we want to identify our location, like they have an X on there, which is, they're doing this for training. I've never seen anybody draw an X on there, but hey, you know, if you got the time, you should identify the right location prior to any procedure. And then we want to anesthetize the area, so you're typically going to place, inject in 3 specific areas. So initially, you want to create a wheel over that rib where you're going to make that incision, so you're providing that superficial anesthesia to the area. And then you're going to want to dive all the way down into the pleural cavity, and while you're aspirating or drawing on that needles, and once you hit air, you know you're in the right spot, and then you want to inject all the way out. So you're injecting until that needle comes back out, so you can anesthetize the whole area. Typically, this is done with some sort of sedation for these patients as well. Sometimes in the emergent setting, like we may not have time to do local anesthesia, so we're typically giving them some sort of IV analgesia to help with this. Then our skin incision, usually 1.5 to 2 inches. A lot of common mistakes I see initially are you guys make too small of an incision and you're not able to get your finger into that area, or chest tube for that matter into the area. So you want to make a large enough incision where you can get your finger and a tube in there. Like a 36 French is like probably index finger, or maybe a little bigger than a normal index finger in diameter. So you have to consider that when you're making these incisions. Now you don't want to make too large of an incision, you're not doing a thoracotomy or anything, but if you do make too large of an incision, it's easy, we can suture it back up. It happens. But once you make that incision on top of the rib, so you use the rib as a cutting board, and then you want to come over the top of that rib with your hemostat or your Kelly, and then you want to dive into the pleural cavity. So you're going over that rib in the 4th and 5th intercostal space until you reach the pleural cavity. So it actually takes quite a bit of force. You're going to have to apply quite a bit of pressure, sometimes a little bit of weight on there, and you'll feel it puncture in. It's a pretty significant procedure. Once you're into the thoracic cavity, you need to spread your hemostat to bluntly dissect the area open so you can actually fit your finger into there. So you're not done just once you place that Kelly in there, because the Kelly's pretty thin. It doesn't have a large diameter, so you're going to need to open it. And it takes quite a bit of force when you're opening those Kellys to spread that area. Now, after you spread open the tissue into the pleural cavity, you then want to make sure you can get your finger in there, and you need to note that you're in the right location. So you do a 360 finger sweep, and we'll show some x-rays here where they probably didn't do that, and that's why that tube isn't in the correct location. And then, so after you get the finger in, you want to remove the finger, and then you place your chest tube into the pleural cavity, and typically we like to angle that towards the apex. A good rule of thumb is shoot towards their opposite shoulder, their contralateral shoulder from the side you're placing that chest tube in. All right, got a question for you. What's the best location? Oh man, I heard people say C. You gotta read the whole answer before you chime in. Yeah, it's gonna be B, okay? So we said that 5th intercostal space, mid-axillary line, somewhere in our triangle of safety is preferred. If you end up, like I said, if you can't go in that exact area, it's better to go higher than lower, because you don't want to perforate the diaphragm, where you don't want to place a liver chest tube. That's poor form. All right, so placement of the tube. So obviously you want to insert the chest tube through the incision, aim towards the apex. Like I said, that contralateral shoulder is a good aiming point for it. it does need to be posterior, so you're not sticking it just straight in, or you're going to end up in the hyla of the lungs, or you might end up in one of the fissures of the lungs as well if you're just going straight in. So you kind of want to angle posterior, and towards that apex or opposite shoulder is the location we're inserting that chest tube. And then it's good that you guys, familiarize yourself with your equipment first. Make sure you guys look at how the chest, look at the fenestrations on the chest tube, the radio-opaque marker, which side you're placing it first. I had one of my preceptors, so somebody's usually assisting you in this procedure, and they're putting the Kellys in the chest tube, on the chest tube for you, while you're inserting your finger in there, because it's usually an emergent procedure. And one of them thought he wanted to like haze me, and he actually clamped the opposite side of the tube that didn't have the fenestration to see if I noticed, and I did. I was like, why would you do that? Like, this is not the time to mess around. But the moral of the story is make sure all the fenestrations are actually into the chest. So there's going to be holes in that chest tube. That's what fenestrations are. And we're going to make sure it's all the way inside the thoracic cavity, the pleural cavity, or else that chest tube's not going to work, and you're going to have a persistent air leak, and you're really not going to do any good with it. Once it's in place, you're going to suture that chest tube in, and during our lab, we're going to show you the correct procedure for it. You can sew it in the opposite way that we show you, and it will work, but there's a preferred technique that we like to use, and that's typically we use one long suture, and we like to place a bite on each side, and then we like to wrap it around the chest tube, what we call like Roman sandal. People used to call it purse string, but that is not the correct term anymore. They like to give you a hard time if you use that term. I know Dr. Castro used to when she taught this course. So we like to call it the Roman sandal, which means you're wrapping in opposite directions around the tube. And that's to help secure it in place. So when we're checking that chest tube every day, when we're looking at our Pleur-evac and we're running that line, we're actually placing some traction on the tube. So that's why it's important that it's actually secured in place. Now, once we suture it, we're going to place multiple dressings and tape the living heck out of it, which we'll talk about in a sec. So chest tube's usually not going anywhere. This is especially important if you guys find yourself in a situation where you're at like a roll 1, or you're the only provider in a smaller facility that has to evac them somewhere. Especially when you're evacing on those small litters that aren't very wide, you need to make sure it's secured extremely well, because anything can tug on those, especially when they're moving them in and out of birds. Things can fall off of the patient if they're not wrapped appropriately. That's why it's important you guys secure that chest tube. All right, and then we place lots of bandages on there. So typically the first bandages we place are a petroleum gauze to help seal around where we put that tube and made that incision. So that obviously creates a seal on there if placed appropriately. So we wrap it around like you see in the top picture that he's doing with that petroleum gauze on there, which is like impregnated with the petroleum jelly. We place that around it first just to help create that seal. And then depending on what chest tube kit you have, the ones that come in the medical equipment sets will a lot of times come with a chest seal with it to help seal around that area. But typically we get 4x4 gauze, and we cut a slit right down the middle, but only halfway through. And we just place it on each side of that chest tube so it kind of interlocks in there. And then we place a buttload of tape like you see in the bottom picture there. So typically silk tape works well, or foam tape are the two common ones you're going to see, and they stick to just about anything. So you tape around that area where the chest tube is. And that bottom picture there, that chest drain, the tape stuck to itself, so that's a good technique to use because you don't know how long that chest tube is going to be on there. So it can macerate the skin if you place the tube directly against the chest wall. So if it's on there for a long time with all the movement, you tend to create like an ulcer or maceration in that area, and then you got to treat another, possibly infection. So what we're talking about with that picture is you take your tape, wrap it all the way around the tube, and then you place the two ends of the tape on the skin so it sticks up like an inch off the skin. So you're not having it directly placed over skin, but you're still securing it in case anything happens and somebody tugs on that. Or when you're moving the patient, they forget to put the Pleur-evac onto the stretcher and it ends up dragging for a second and you're like, what the heck? So this does happen, so it's important we secure this thing appropriately, all right? And then our Plurivac. So it's important we have all these set up prior to our procedure. The different brands, different models, they all are different, and you have to place saline in them into certain areas. So they have a water seal chamber, and then they have a suction chamber that has to have saline in there. And the reason we have these different chambers is so that it creates a one-way valve. So we're basically, so air leaves the chest or blood or fluid and nothing enters it. So we tend to use a bunch of different brands. So you need to look at which one you have first. So it's good training to look at all your equipment. And if all else fails, they actually have instructions usually on the back. So it's important to read those and figure out where you're supposed to place that water in prior to any operation. So it's nice that if you guys, typically like when you're in process at the ER, we would teach you guys how to do this, but some places may not and it might be busy. So it's important you guys look at how this operates. But as you can see, you have like one tube that goes, or one tube goes to the chest tube, one goes to suction, and then you got your different chambers on their water seal and suction. So you have to place water in those. That's why you got to look at where they want you to place them, or else the chest tube is not going to create that one-way valve. And then you have to obviously attach your Plurivac to the chest tube. You also, most of them come with what we call like a little Christmas tree, which is like a little step-up valve to accommodate multiple sizes of tubes. So you need to make sure you have that with you. So some of those chest tube kits that you can order for your units, they don't come with those, or they may not come with them. So you need to consider that and inventory and inspect your equipment and learn how to use it preferably prior to performing the chest tube. But there are different types of systems, so you need to pay attention to that. And then we attach it to the chest tube, and then we secure it typically with 3-inch silk tape, and we tape a lot. Throw a lot of tape on there so it doesn't come undone. And then you need to look at your air leak meter. So there's a suction chamber which should bubble, and then there's an air leak chamber or water seal chamber. So you need to inspect that. So it should bubble initially after attaching the chest tube, and it should settle within a couple minutes after you attach everything appropriately. So if you see that water seal chamber bubbling after that, that means you have a leak somewhere and you have to figure out where that leak's coming from. And we'll talk about some techniques here. You can, if you have that consistent leak, an easy way, since you have all that tape on there, you've taken all that time to place that chest tube in there, and it looks very pretty afterwards. You usually don't want to take all that down and check whether you're in the thoracic cavity. Now, the chest x-ray is very helpful. You can see your fenestrations going into the pleural cavity. However, another technique is you can clamp that tube, and that will help you check the water seal. So when you place the clamp between the air leak and the water seal chamber, like the bubbling should stop. If the bubbling stops when you first clamp, the air leak's at the chest tube, and that's a good indication that maybe you're not in the thoracic cavity or you have some sort of leak around it. So those are just simple techniques we tend to use if we have that continuous bubbling in our water seal chamber. And then our post-placement chest x-ray. So you need to make sure that last fenestration is in there. It has radio-opaque lines across it, and the tube should be hugging the chest wall, and it should seat in the apex. So what do we see in these two x-rays here? Do they both look good? I mean, I'm asking, so probably not, right? Yeah. Which one's good, which one's bad? Yeah, the one on the, what's wrong with the one on the bottom? Yeah, it's subcutaneous. So I don't know how they got it all the way up there. That would be very painful, obviously, for the patient. So hopefully they were unconscious for this. But basically, they probably didn't do that finger sweep to ensure they were inside the pleural cavity. They made an assumption that they were in the right area, and then they inserted that too. I would think there'd be a lot of resistance, but maybe not. Maybe if you like hit some fascial line, maybe not. I don't know how they did it, but as you can see, it is hugging the chest wall, just the wrong side of it. And then it's above this rib, so it's obviously superficial. This tube is not doing anything for this patient. That's why it's important we get that chest x-ray afterwards so we can confirm placement. And sometimes there are, so things do happen, like I've had a chest tube, it goes into the thoracic cavity, but it hits likely somewhere on the lung and then it angled down halfway in the chest. So it's like, it's in the pleural cavity, kind of the correct place, but something happened where it bent that tube to go inferiorly, which is less than ideal. So we had to fix that. It happens. The most important thing is that that tube is not in the diaphragm or the liver or the stomach. All right, and then maintenance of the chest tube. So we place the chest tube, is that it? We're done? No, unfortunately not. So the initial setting is on water seal. We don't immediately hook it up to suction on the wall. We do place it on wall suction typically an hour or two after we insert it. And then it's usually on intermittent suction on the wall. It's not placed on continuous suction. And then the lung will gradually re-expand as that patient is inspiring. And that should hopefully force the lung against that thoracic wall, and it eventually pushes the air out. Technically, there's not supposed to re-enter for using that water seal, so if everything is correct and everything is inside the pleural cavity, we shouldn't have any water leakage in that water seal chamber. And then you'll typically get 100 to 150 milliliters of fluid out of the lung daily. And then that Pleurovac needs to be below the chest or wherever you inserted it. So typically they have little, they don't balance really well, but they come with little, little legs on them that you can turn outside. They also come with little handles that attach to the bed, so it's important that we're just not leaving it on the ground, especially if they're like a polytrauma patient with other injuries or walking around. We don't want to knock that Pleurovac over. Then we need to consider pain control, antibiotics, and prophylactic treatment for these patients. So what do we do every day with this patient? So when they're on the ICU or the ward, we need to check these every day. So we're looking for any air leak. We're checking the drainage. We're obviously doing a physical exam on our patient, evaluating pain level, like obviously their respiratory effort. And then we need to get a chest x-ray as well. And then have you guys ever heard of the dope mnemonic or troubleshooting? So these are like the four most common reasons that may cause some sort of complication with that tube. So we typically use the dope mnemonic. We start with, is it displaced? So we want to check that it hasn't been, no traction on it, those fenestrations haven't been pulled out of the pleural cavity, so we want to run the length of our tube. Then we need to look at, is it obstructed? And a lot of times we can just squeeze that tube in a line to check for obstruction. And a lot of times that's probably the most common reason that we have some sort of dysfunction of it. And typically we just squeeze that tube and we can get it flowing again. Then we need to look at the position. So a chest x-ray is very helpful for position. And then, is there any equipment failures? Or suction not working? Did somebody knock over the Pleurovac? Did we not fill the water chamber up appropriately? So those are all considerations we need to do on a daily basis when we're monitoring a patient with a chest tube in there. All right, we got a question for you. Give you a second to read this. Yeah, I heard it on there, B. First, examine your patient. Yep. So like we said, every day you're gonna, have to evaluate this patient on rounds when they have a chest tube in. And we first need to obviously establish some history from our patient, looking at pain, then we need to do a physical exam on them. And then we need to check that chest tube insertion site. We need to verify that the tube is still in the correct place. Now this one, happened after we moved the patient, so likely it's not secured well enough like we were talking about. what we're supposed to do initially with that Roman sandal technique, placing all of our dressings on there. So something happened in that area to cause an air leak. So at this point, we likely examine them and get a chest x-ray and notice that those fenestrations aren't within the pleural cavity. All right, and then maintenance of the tube, we keep it on suction until there's no air leak. And then we get a serial chest x-rays every day, so they had resolution of their pneumothorax on chest x-ray. And then we consider removal when there's no air leak on the water seal, so there's no bubbles in there. We got less than 200 milliliters of drainage in the last 24 hours, and there's no pneumothorax on x-ray. At that point, we can consider removing the tube. And another reason, the way we tie those tubes in, the reason we use the Roman sandal technique, which it'll make more sense as you do the procedure, but I would recommend watching those videos. We can also use that same suture to close the wound if we tied it appropriately on there. So we can typically snip one of the knots, unravel all of that silk we have on there, and then as we pull the chest tube out, we can take those two ends and close that wound as well, so we don't have to do any more procedures on that patient. So that's why we tie it that certain way with the Roman sandal. One is to keep the tube in place so we don't have, so we can avoid any displacement. But the other, so we can close it up afterwards as well, and we don't have to do another procedure. We don't have to re-anesthetize the area for sutures, okay? And the video will show you that, and we'll practice that at our live tissue lab. So obviously when we remove that chest tube, we need to take down all our dressings, so we have all of that tape on there, which usually is a lot. And then once we get the tape off, we have to take those 4x4 dressings we have on there off, and then the petroleum gauze. And then, depending on whether we need to prepare, it's always good to have sutures available in case something goes wrong. So hopefully we can use the suture material that's already in there, but if not, then we need to prepare our sutures. And then we should get some fresh petroleum gauze to help seal that area, just to ensure that we have a good chest seal after we take that tube out. We don't have any air leaking back into the pleural cavity. And then we usually have them take a deep breath and hum as we remove the tube, and we pull it quickly. It's like we pull it out of there like we're starting a lawnmower. We remove that tube usually relatively fast. And then we tighten and secure the sutures. And then we want to place a bandage over the site and obviously get a chest x-ray after we remove that tube. All right, so quick review. 3 things we're looking at on the chest x-ray: obviously position of the tube, location of that last fenestration, and then is there any residual pneumothorax. And then every day we need to make sure there's no air leak while on water seal. We need to calculate the amount of drainage over the last 24 hours since the last time we checked. And then we need to get a chest x-ray daily and look at the chest x-ray for any resolution. And then we can pull that tube when we don't have no air leak, less than 200 milliliters drainage in 24 hours, and no pneumothorax on chest x-ray. All right, what questions do y'all got? Gotta have something. I need a question.
I've always been a little confused with the water seal, and how that works. Can you explain that?
Probably. Let me go back to this picture here. So here are you have the different chambers on here. So you have your suction control chamber here, which is going to your suction source, and it has an air inlet here, and this water seal chamber is, the reason we have this here is so no air can come back, air can come from here, but since we have this air inlet that's creating suction, and then this water seal, it's supposed to not allow air back into this side of the chamber and theoretically back into the chest if it's working appropriately. If that makes sense. Maybe not. I don't know. Makes sense in my head. Whatever. No, I'm just kidding. Yeah, you're just placing some water there so you can create a one-way valve.
So it's draining into the right side?
Yep, it's drained into the trap chambers, and they have, you can see here, they have little measurements on it, so you can measure that fluid every day, and you kind of mark on there every day how much fluid was in there. Sometimes you mark it, oh, sorry, sometimes you mark a date on there.
So the right side is like a barrier to any
Yes.
air.
And the reason we have this other water for the suction source is because our wall suction provides like a significant amount of pressure on there, and it can be harmful to the lungs. So we use this to decrease the pressure from our wall suction, because typically, you know, the wall suction, we can be sucking out secretions that are extremely thick. We can be sucking vomit, you know, vomitus out of there, or emesis. It can be used for everything, blood included. So it's too powerful of suction to place on a patient, to place in the pleural cavity. So it would basically like suck your lung straight out of there if you hooked it to wall suction. That's why we have this water here, so that it decreases the amount of suction from the wall. And that's why we do it on intermittent suction as well. So that's what this water is for. And then this one is just to create that one-way valve so air can leave, but it doesn't enter back in. All right, any other questions? I saw somebody else's hand go up. Stop. Yes. Yeah, you can push back in. Yep, yep. We'll typically have to take all the dressings down. No, we don't put a new tube in. We typically just insert that tube back into there. And that's why we're typically giving them like some sort of prophylactic antibiotics as well. You know, one to avoid any sort of pneumonia, but also to cover for any of that like skin flora that can become infected and create cellulitis in that wound area. What else? All right, if that's all you got. I'll hang out for a few minutes if anybody has any questions, if they're too embarrassed to ask.